my name's Diana. Today we'll be reviewing IV therapy. So first we'll go over some goals and objectives. So first we'll identify the need for IV therapy, the who needs it and the whys. So patients who need any kind of fluid resuscitation, medications, even blood. So at the end of this, hopefully we will be proficient in the equipment needed to place an IV. And we'll be able to demonstrate the ability to properly place an IV. Lastly, we will identify any complications, such as infiltration, infection, or even in an artificial limb. So we'll discuss who has prior knowledge of IV therapy. Some of us know more than others do, so we can catch everybody up on who knows what. So what is IV therapy? IV therapy is intravenous therapy, so that means that it is fluid or something going through the veins. Again, why do we do IV therapy? For fluid resuscitation, medication administration, blood transfusion, or even sometimes taking labs. So we'll go over some anatomy of veins, some fun facts that some people may or may not have known. So there are 3 layers to the veins. So there's the tunica intima, which is the innermost layer of the vein. It's made up of endothelial cells. These are smooth so that the delicate blood can run through them nice and smoothly. Then we have the tunica media. So that is the middle layer. This is made up of smooth muscle cells and elastic fibers. This area is thinner than what the arteries would be. And lastly, we have the tunica interna. So that is the outermost layer. It's made of connective tissue, and basically it's used for a structural support. So what's the difference between arteries and veins? So veins carry blood to the heart, and they have valves, and these valves are there to stop any backflow. Like I said, they are thinner and they are stretchy. So arteries carry blood away from the heart. So these don't have valves, so the blood is just continuously flowing. They are thicker and they're stretchier. So let's go over our equipment needed. So obviously we will need our gloves. We have our antiseptic wipes. We have a couple sizes of catheters. These are not self-occluding, so we'll show you the smallest size. So this one here, once we retract the needle, this is just a flexible catheter that will stay in the vein. This way the patient can move without any pain or anything like that. So we will have our Sharps container. Then we have our saline lock and our saline flush. We have our securing devices. If you do not have what's called a tegaderm, then you can use either tape or a Band-Aid. And then this is our little arm here that we're gonna discuss. So before we get into the demo, let's discuss what infiltration is. So infiltration is accidental leakage of a solution in the surrounding tissue. So this can happen when the catheter gets dislodged, whether the patient's just moving around a lot or they pull it, or when you are inserting the catheter, you go through the vein. So this will cause some pain, it'll cause swelling, and then eventually that area will become cold to the touch. So if some medications are infiltrated into the skin, it can cause necrosis of the surrounding tissue. So you also want to be aware when you're identifying where you're going to do your IV that there's no infection or anything like that in the area. And then lastly, you want to make sure that it's actually a real limb. So we will get our BSI on. Okay. We will grab our tourniquet and place the tourniquet on the arm. This has to be nice and tight so you can be able to visualize. So we'll take our antiseptic wipe and we will go a nice big circle, and then we'll take another one and we'll just go from top to bottom. All right, so let's get our saline. So the saline lock is an empty tube, so it's just clear, and we want to prime it so that there's no air when we do either give medications or fluid. So you can identify that it's done by having some drips. So for this sake, we're going to use a 20 gauge IV. Make sure that we go bevel up, and we're going to hold the skin nice and taut, and we're going to go at a 25-degree angle, and then we'll let the patient know 1, 2, 3 pinch, and you should see some blood in that catheter there. That's how you know that you're inside the vein, and you will advance till you hear that pop. Release that. And then we're gonna apply some pressure so that these are not, like I said, they're not self-occluding. And we'll tighten that. You can draw back some to make sure that you still have a good return, and then flush. Sometimes your patients will say that they get a funny taste in their mouth. That's normal, that's just a saline. And then we'll apply a Tegaderm, like so. And we will discard that into our sharps container, remove this extra. So there is a little piece of tape here that you can place on top of the IV, and you can date it this way. The hospital knows when that IV was placed, and then we'll just secure nicely with a nice chevron and secure that, and there we go.